All right, hello. Thank you so much for listening to this talk titled Post-Intensive Care Syndrome, or What Does It Mean to Be Okay? And my name is Daniela Lamas. I'm an instructor at Harvard Med School and an attending physician in pulmonary and critical care medicine at Brigham and Women's Hospital here in Boston. I have no relevant disclosures. Just take you through what we're going to talk about today. We'll just first have some epidemiology, then go into a definition of post-intensive care syndrome, talk about its characteristics. We'll go into briefly to talk about post-intensive care syndrome as it pertains to families. Then we're going to talk about possible treatments and really then move into research and clinical efforts. And I want you to remember the following take-home messages. Some of the things that I say might make you sort of feel negative about ICU care, but remember, we are saving lives. But the things that we do in the ICU have long-term consequences beyond saving lives. And that when it comes to thinking about treatments and different solutions, the standard solutions might not work here. We're going to need to be creative to solve these problems. And I'd love to empower everybody who's listening to think about ways to solve these problems. How many ICU survivors are there? So each day in the US, there are 70,000 adults who are cared for in ICUs. That means that there's about 5.7 million ICU admissions per year, and of these, 4.8 million of these people will survive. This takes up greater than 1% of the GDP, and so a lot of effort, clearly, and necessarily has gone to survival in recent years. However, thinking about the well-being of those patients who survive has largely been understudied. Increasingly, ICU researchers have looked at the following question, which is what happens to those who survive the ICU? Really, our understanding now of ICU survival began with anecdotal evidence. Back in the 1990s in Germany, there was a young man. He suffered ARDS from the flu, I believe. He was on ECMO for weeks. He had episodes of septic shock, multi-system organ failure, a months-long ventilator wean. By all accounts, he was lucky to be alive, and indeed he had an excellent recovery with no evidence of cognitive impairment. His physicians wrote retrospectively in a piece that they wrote in Chest in 2013, many years after, that they remembered this patient and they remembered seeing him, both in the ICU when he woke up and then on the general medical floor, and that he should have been content, but he wasn't. He was tense, he was withdrawn and anxious. He didn't talk to anybody, and then finally one of the physicians sat with him, and after a time the patient asked, "Is the war over?" The physician probed, what was he talking about? He described that in his past weeks to months in the ICU, he had experienced essentially what seemed to be an imaginary war. His family was killed. He imagined that he had been hogtied, naked and cold, tortured. These images came back to him at night in nightmares, and during the day as flashbacks. And his doctors wrote in this chess piece that this man was the veteran of an imaginary war that had been waged in his mind over weeks to months in the intensive care unit. So his physicians actually went on and did some research, which I'll bring up later, about the prevalence of post-traumatic stress in patients in the ICU. But that really remained relatively understudied, and in the interim, the anecdotal evidence climbed. In 2003, a woman named Nancy Andrews was hospitalized here at Brigham and Women's Hospital after suffering an aortic dissection. And she too described that she went through visions that she portrays here in art. You can see this is her artwork. And found that there were really memories that came home with her of things that had never happened. She imagined that there had been bugs on people's faces, that she was drowning in a well, that her nurses had created a sadistic plan to kill her. She ended up getting some sort of public interest in her story from her artwork, and she actually did a TEDx talk about her experience relatively recently, but this has taken years to gain public attention. I'll share with you some quotes from her TED Talk. "For 3 weeks I was held in a room. I was tied to the bed if I tried to get away. I couldn't talk. I couldn't eat. I was not allowed to sleep. Groups of people would enter the room and look at me and talk about me, and I was sometimes undressed in front of a small audience. I was shot full of drugs. I was too weak to move. I could not see my body, but it had been cut nearly in half. Insects crawled on the walls and ceilings. Where was I? They asked me every day, and I never knew the answer. I was in the ICU of one of the best hospitals in the world, where nurses and doctors were using all of the most current medical know-how to save my life. In reality, the ICU is a torture chamber. If you take away the knowledge that everyone is trying to keep you alive, what is actually happening can be pretty dreadful. Being on a ventilator is a nightmare. Your ability to communicate by speaking is taken away. If you're agitated, you will be restrained so you stay in bed and don't hurt or kill yourself. And that was Nancy's recollection of the ICU. So far I've only given you a little bit of anecdotal evidence, but it's all really striking, and more recently there's been a lot of attention in the lay press to these issues. I show you a couple of headlines, one from the Boston Globe, which I wrote. This is how I became interested in this topic, one from the New York Times, and then even an expert Q&A from CNN.com, how can I get help for PTSD induced by an ICU stay? But it was more than anecdotal evidence that led to our current understanding of what happens to patients after the ICU. So I show you here the title from an article in 1999 in the American Journal of Respiratory and Critical Care Medicine that was one of the first pieces of research to look at the neuropsychological sequelae and impaired health status in survivors of severe ARDS. And so what these authors did was that they looked at these patients over time, and they found that while these patients' lung function could return to near normal, these survivors remain limited. And they were limited not by their impaired lung function, but by weakness and cognitive dysfunction. And so this was really one of the first studies to quantify what these patients were telling us, which was that alive is not the same as alive and well. So just to delve a little more into this particular study, so 1 year after the onset of ARDS, these researchers found that about 3/4 of their survivors had cognitive function impairment, including impaired memory, attention, and concentration. About a half had decreased mental processing speed. 30% had global cognitive decline. And what did that mean for these people? Well, it meant that they had trouble remembering their appointments, say their doctor's appointments. They had trouble remembering what to buy at a grocery store, what people said to them, if they even took their medications, following directions. Some people described that even while cooking, they would forget they had something on the stove until the food was smoking and burning. So these are not subtle issues, and they're issues that create impairments in their everyday life and also in their ability to follow directions in terms of their medications and appointments. So the evidence really, as we showed, has been mounting. And this led to, in 2010, a group of about 30 stakeholders. So physicians, physical therapists, patients, patient advocates got together in a room in a Society of Critical Care Medicine funded conference. And they talked about what they could do to increase public awareness of these problems. And so what they concluded was that awareness would be improved by the use of a single term. We needed a word for all of these impairments that happen for patients after the ICU. And so they decided that they would call this post-intensive care syndrome, and they'd abbreviate it PICS. And comes with a definition: new or worsening impairments in physical, cognitive, or mental health status arising after critical illness and persisting beyond the acute care hospitalization. And these impairments, I've shown you a little bit in mental health, are characterized by anxiety, post-traumatic stress, depression. The cognitive impairments are really what I described from that earlier study in '99, which had been validated in multiple other studies. Problems with executive function, memory, attention, mental processing speed. And then the physical impairments, and these are obviously the most visible. Pulmonary function problems, which do improve over time, but what is more persistent are the neuromuscular problems and problems in physical function. So just to hone in a little bit more now on each of these particular domains of post-intensive care syndrome. So as mental health, we mentioned anxiety, depression, post-traumatic stress. I show you here another drawing from Nancy Andrews, and you can see she imagined herself as this wounded bird with this scar down her chest, and that was what she imagined. You can see here there's a hospital bed in here. And this is really her trying to depict these visions in her delirious mind. So what is really the burden of these mental health problems? So I show you here one study from a larger group called the Brain ICU Cohort, which are patients at that are in a study led by investigators at Vanderbilt who were sick enough to be in an ICU with respiratory failure, cardiogenic shock, or septic shock. And they looked at these patients and they enrolled them. They excluded people who had been mechanically ventilated before their current ICU admission, who had had significant pre-existing cognitive impairments, and ultimately enrolled 820 patients and then evaluated them at 3 and 12 months. And this is a really useful study when you're thinking about post-intensive care syndrome, because these people, they didn't just find them afterwards, they identified them when they were in the ICU and then followed them over time. So this allows them to really look at ICU level risk factors for developing these problems. So post-traumatic stress, really honing in on the prevalence of post-traumatic stress after the ICU has been problematic, largely because a lot of different investigators use different tools. So there isn't one standard screening tool that says, all right, everybody should use this for people who survive the ICU, and if you screen 20 out of 25, you have post-traumatic stress. So using the tool that they used, we have 7% of survivors with PTSD up to 12 months. So, however, depression is a lot more pervasive. So 1/3 of these people up to 12 months, and you can see here that's in all different cohorts of age, are actually depressed by the Beck Depression Inventory Score. Now, how about the cognitive impairments after critical illness? So the brain ICU study looked predominantly, while it also explored depression and anxiety and post-traumatic stress, it looked predominantly at long-term cognitive impairment. And one of its goals was to look at what in the ICU is perhaps a predictor for a greater burden of long-term cognitive impairment. So I show you here the global cognitive scores in survivors of critical illness in this cohort. And as you remember, it's about 800 patients who were sick enough to have septic shock or respiratory failure in medical and surgical ICUs. And here, separated by age, these are relatively young people, sort of more middle-aged people and older people. And you can see there isn't really a great difference in their overall scores. These are the median scores you can see here in this thick line. And here, all the way up here, far away, is what the age-related normals would be. And this demonstrates that the median scores for these patients are much more similar to mild cognitive impairment, similar to a mild traumatic brain injury or Alzheimer's disease than to the normals. And this is true up to 12 months, and it's true regardless of age. So what were they able to look at in the ICU that might be a predictor for one of these bad outcomes? And really what comes out is that delirium in the ICU and duration of delirium is a significant predictor of long-term cognitive impairment in survivors of critical illness. So you can see here for each standard deviation away from normal, cognitive scores are associated with increased days in delirium, meaning that longer amounts of time of delirium in the ICU means a higher risk of cognitive impairment afterwards. Clearly that doesn't actually tease out cause and effect, but it is important to think about. So how about the most visible, functional disability? So I point you here to another New England Journal study by Margaret Herridge in Canada looking at functional disability 5 years after acute respiratory distress syndrome. And really what this is intended to show you is that these physical impairments are long-lasting. The median age of these patients is 44, and we see in the prior study, and prior graph, and I'll go back and show you that at 6 and 12 months, the mean values for strength for these patients are actually 92%, 93% are predicted. However, their 6-minute walk is only 64, 67% are predicted, and their overall physical function score is 61 and 67% are predicted. So you can see here that these percent are predicted even in a median age of 44 years, up to 5 years of study, these patients are able to walk about 2/3 of what you would be able to predict for their age. And so they looked at patient baseline status and found a significant association, interaction of mean daily dose of steroids and ICU length of stay with these impairments. So we have delirium, steroids, and ICU length of stay as being associated with cognitive and physical dysfunction after the ICU. So here we have this problem. It has a name, post-intensive care syndrome. And I want you to think a little bit about whether these are things you tell patients about when they leave the ICU. And maybe the patients themselves are not at a point where they're able to hear these things or understand them, but what do you tell their families? And maybe what do you tell their families not just about what their loved ones might experience moving forward, but what the family members themselves might experience? So I'm going to tell you a story about a woman who I took care of in the ICU actually a couple of years ago. So she's 51. She has given me permission to tell her story anywhere. So she's 51. She had flu from H1N1. She actually had declined a flu shot, for what it's worth. She developed from this, healthy woman, but developed from this ARDS, acute kidney injury. She was on dialysis. She was in shock. She was on the ventilator, but she wasn't getting better. And so ultimately the decision was made to put her on ECMO. She was on multiple pressors. She was on ECMO for days. Finally, when she ended up off ECMO, her ventilator requirements decreased, but she was still unable to be extubated. She was profoundly weak. She ended up trached. She was delirious. She spent 2 months in the ICU and then a longer period of time at rehab. So I saw her about 1.5 years after she left the unit, and I've seen her a couple of times since. And it's been about 3 years, and now she's back to her prior quality of life, and even perhaps better, she actually recently married for the first time in her 50s and moved to St. Lucia, or St. Croix. These are apparently the same to me, but so maybe she's even better than she was. But anyway, she remembers little of her ICU stay. She does remember some anxiety, frustration at rehab, but it seems like nobody was hurt by her ICU stay. It was strange and scary and long, but she doesn't remember it. Now she's fine. But then I talked to her brother, and her brother, she tells me, has never been the same. He has developed significant anxiety. He has flashbacks to the decision-making periods in the ICU, to his belief that decisions that he made might kill her. How is she going to react to decisions he made? And so he's really developed possibly post-traumatic stress from this. So he's not alone. I mean, family members really are the collateral damage of an ICU stay. And so post-intensive care syndrome, of course, focuses first on the survivors, but then it focuses in as well on family members, and also offers an alternate sort of acronym for post-intensive care syndrome family. And these people don't develop the same cognitive and physical impairments, but they do develop impairments in mental health, anxiety, post-traumatic stress, depression, complicated grief. So looking a little more specifically at one-year outcomes in caregivers of critically ill patients, I take you to another recent New England Journal article. What they found, they looked at patients who had been mechanically ventilated for 7 or more days and who actually had survived. And they looked at what do these caregivers look like? Well, the mean age of the caregivers was in their early 50s. Most were women. 61% were caring for a spouse. And initially, at the time of the ICU stay, 67% described high levels of depressive symptoms. At 1 year, this percentage had decreased to 43%. So you can see that while the depressive symptoms decreased at least partially with time in a great majority of the caregivers, in 16% the depressive symptoms didn't decrease in time at all. And so who were these people with worse mental health outcomes? These are people, interestingly, of a younger age, who described a greater effect of patient care on their other activities, who had less social support, less sense of control over their life, less personal growth from the experience of caring for their sick loved one. And there were no patient variables that were consistently associated with caregiver outcomes over time. But this is important to think about because as the population ages, as there are more people who are caring for their loved ones who would previously have died during an ICU stay, but now did not die, are still alive, and are still alive for a matter of weeks to months to even years, the burden on caregivers grows greater, and that's something that we really don't focus in on very much at all. So what can we do about any of this? Well, it's important to note that there aren't really very many studies about interventions for post-intensive care syndrome broadly. And first, thinking about this, our emphasis should be on recognition in the ICU, who is more likely to get these outcomes, and education to patients and their family members. There are several studies on prevention, and it's important to mention that really prevention is key. And a lot of the things that we're doing in the ICU and that you're hearing about in other lectures here, that these best practices in the ICU have the potential to reduce post-intensive care syndrome, decrease ICU length of stay. As you can remember, I showed you in the Margaret Herridge study that longer ICU length of stay, not surprisingly, is associated with worsening physical function up to 5 years out, decreasing the duration of mechanical ventilation, and decreasing delirium. And as we know now, we screen regularly for delirium in the ICU. We decrease meds sedatives that are linked to longer durations of delirium. And our hope is that this will decrease the burden of cognitive dysfunction after the ICU. That's really interesting, because what that ends up suggesting to us... Oh, I didn't see you pause, so I was like, all right, I'll just keep going.
So this is...
Sorry, it's because I moved and my foot was tangled in this, and then I pulled it off. So you can tell me when I should start again.
Okay, restarting slide 37.
All right. So here, just to pause for a second and think about daily interruptions of sedation, which is something that we do to decrease delirium. You might think that in trying to decrease delirium, we actually end up causing worse psychological distress, interrupting sedation. Patients wake up, they see where they are, they're perhaps intubated, restrained even, unable to move. Is that actually scarier than just being sedated and delirious? Well, paradoxically, perhaps, there's actually evidence for reduction in PTSD in groups of patients who undergo daily interruptions of sedation. Again, from the Blue Journal, the American Journal of Respiratory and Critical Care Medicine in 2003. So prevention is key. Interrupting sedation does not worsen outcomes. But there are patients, like the 51-year-old woman with flu ARDS that I told you about before, like Nancy Andrews, the woman with the aortic dissection, like that very early patient in Germany, who are going to be sick enough that they're going to need sedation, that they're going to be on ECMO perhaps, that they're going to have a long ICU stay. So what can we do for them? Once they leave the ICU, is there anything that we can do? The evidence for this is really scant. And I want to point you to one study from Critical Care Medicine in 2012. So you remember the brain ICU cohort that I told you about out of Vanderbilt? Well, the investigators there said, we have these people, we're describing cognitive dysfunction in these people, maybe we can also try to help them. So they did a very small pilot and feasibility randomized controlled trial. So they randomized a small number of people, 8 into the control group and 13 into the intervention group. So these were ICU survivors from the cohort that I told you about with cognitive or physical impairment at their time of their ICU discharge. Their intervention consisted of in-home cognitive, physical, functional rehabilitation via telemedicine for 3 months. So patients got 6 televisits. They also came in for 6 in-person visits. And the televisits were really coaching them through cognitive tools that they used on the internet, sort of in-home physical therapy and functional improvements. And then the investigators looked at outcomes at 3 months. And so the outcomes that they looked at were this Tower Test Achievement Score that really measures cognitive outcomes. And what they found was that at the 3-month follow-up study, you can see the circles are the control and the triangles are the intervention, that there's a significant difference. These patients are similar in their Tower Test Achievement Score at baseline, but that those who are in this intervention group do actually have greater scores on this test that does have a good reflection of cognitive function. So suggesting that potentially there are interventions that we can make beyond education that actually improve the outcomes of our ICU survivors. Another intervention that has been shown to improve some of these post-intensive care syndrome outcomes, specifically post-traumatic stress, is an ICU diary. And so when you think about the ICU diaries, I want you to think as well about that study that I mentioned, looking at how daily interruption of sedation actually has evidence for a decrease in PTSD. So what does that suggest? What that sort of begins to suggest is that it really are these delirious, hallucinating sort of memories that actually cause PTSD, not necessarily the reality of being in the ICU. So back about 20 years ago, a woman named Christina Jones, who's a nurse in the UK, decided that she was interested in what happened to her patients after the ICU. And so she wanted them to come back and just kind of talk to her. So she tried to start this group, and she tried to start it in the hospital, but nobody came. And when she finally found enough people to ask why they didn't come, they said that they were scared to go back to the hospital. They didn't want to go there. They had really horrible negative associations they were almost unable to overcome going into this place. So she decided to hold the group in a pub, and people did come, and she ended up getting a critical mass of people enough that she started to see some patterns. And so I'll share with you what she told me, that she started to see this pattern of people with flashbacks and nightmares. These were people who had very little factual memory of what had happened in the ICU, but they also had these hallucinations, like the hallucinations that early patient in Germany told us about, that Nancy Andrews described and drew. Paranoid delusions of nightmares and alien abductions and nurses trying to kill them. And she says that seemed to be the precipitant for PTSD for a portion of these patients, that they couldn't reject these memories. So this led her to think, all right, well, what if I can create an actual narrative that these people are able to return to, and that almost is able to write over this scary narrative that they have, in addition to doing interventions like decreasing sedation, like lightening and lifting sedation each day. And so this was the idea behind an ICU diary. So I show you here a page from a sample ICU diary where you have your ICU team, and each person has a name and a face, and they're described up here. And the ICU diaries work in this way that they're entered, the information is entered by family members, it's entered by the care team. And really the idea is that it's a daily recording of what actually happened in the ICU. And so she thought, well, maybe I should study this. And so in 2010, she published a study looking at intensive care unit diaries and finding that these actually do, in her cohort, reduce the onset of post-traumatic stress disorder following critical illness. And so what she did was that she took patients who had required more than 72 hours in an ICU and some of the patients had a diary, some did not. And she assessed PTSD at 1 and 3 months. And the diary was given out to patients at 1 month after that first PTSD assessment. And what she found was that the development of PTSD at the 3-month assessment was lower, was less in patients who had actually seen an ICU diary. So ICU diaries, there's a little evidence behind it. There's also a little bit of evidence of it improving outcomes for family members, particularly family members whose loved ones have died. Should everyone do ICU diaries? I show you here a screenshot from ICUdiary.org where groups and hospitals who have active ICU diary programs have entered themselves. And you can see that this is really clustered in Europe and the UK, and Norway, Sweden, and very sparse in the US. Clearly some groups are doing ICU diaries without actually putting themselves on this map, but it's not yet become something that's really taken off. So in terms of treatment, post-intensive care syndrome, we talked about ICU diaries, about the idea that there are potentially cognitive and physical therapy sort of bundled interventions that can improve outcomes, but that really prevention is key. And when it comes to family members, I think that message is similar. We are trying to improve communication via frequent family meetings, open visitation, family members on rounds. And there's observational data that suggests that having family members on rounds and really actually does not decrease resident learning or increasing rounding time. Family participation in the bedside care of patients, like applying lip balm or massage. But there's no real clear data on a lot of these interventions. We do know that we have to kind of be thoughtful about what we do in terms of communication interventions to families, that just giving people information in and of itself is not necessarily beneficial. I just want to mention a recent study looking at proactive palliative care style meetings with patients, with families of patients who had been on the vent who were not expected to wean. So this group of patients who were looking toward tracheostomy. And the thought was that having proactive palliative care meetings with these families, not by palliative care clinicians, but by teams who are using sort of palliative care approaches, that would actually reduce anxiety, depression, post-traumatic stress in these families. And they found no reduction actually in post-traumatic stress or anxiety, and perhaps actually an increase toward an increased amount of PTSD in the family members who did have these meetings. And really what that suggests is not that meetings are bad, not that palliative care style interventions are bad, but really that thinking about the delivery of information is important, and more information is not necessarily better depending on how it's delivered. So let me take you now to some research and clinical efforts. So just to focus in on my own experience and work here at the Brigham. So overall, starting in the UK in some 20 or so years ago, there's been an interest in having what's termed generally an ICU recovery clinic. So we know that these outcomes exist. We don't really screen for them in any standard form. We don't know if screening for them actually helps people, but it seems like we should know. As I said, there are 70,000 patients in an ICU in the US at any one time, and so much attention, so much money is given to their survival, but so little to their well-being. Should we at least see them afterwards, find out what's going on? So this is the idea behind an ICU recovery clinic. And so Vanderbilt has probably one of the most established clinics in this country, and we've tried to start our own clinic here. And our goal here is really to screen for the things we talked about, for mood disorders, for PTSD, for cognitive dysfunction, for insomnia, to offer medical follow-up, to offer medication reconciliation as well. People leave the ICU with many new meds, many of which, sedatives, sleeping meds, they might not need. And really to offer communication with a primary care physician, to act as a bridge that kind of opens this black box of the ICU stay and creates an element of continuity that might not exist otherwise. So we've started this clinic and we've seen a handful of patients so far, and we've done so knowing that there's little data on post-ICU clinics having any efficacy. In fact, the biggest study of an ICU clinic, this study called the Practical Study of a Nurse-Led Intensive Care Follow-Up Program, actually randomized patients to a post-intensive care syndrome clinic versus no clinic, standard of care. The clinic was nurse-led. They saw patients at 3 and 9 months, did some psych screening, physical rehab, and the investigators looked at health-related quality of life at a year. They looked at anxiety, depression, healthcare costs, mortality, and what they found was that there was no difference. They were unable to find any benefit to the ICU clinic. And this raises a lot of questions. One, perhaps there is a role for a physician in these clinics. Perhaps the design of their clinics is the problem. But I think it's worth thinking about as well that maybe the outcomes that they're looking at aren't necessarily the outcomes that we should be looking at to gauge efficacy. Maybe there are other outcomes that matter, and maybe we'll need to turn to patients and families and think more about patient-centered types of research to find the outcomes that matter, and then to be able to gauge the efficacy of our interventions based on these outcomes. So we do continue to have questions about ICU recovery clinics, and if that's something that any of you do in your hospitals, I think it's really helpful to think about when to intervene, how often. We try to see patients within a month of their return home. That's arbitrary. Who's likely to get better? Is it helpful to see everybody who leaves the ICU? That doesn't seem efficient, but who should we see? And overall, are they useful? And really, beyond are they useful, how do we gauge useful for this population? So our experience really has been that it's hard to get patients to come. We've had limited referrals. And that's for a lot of reasons. We're a quaternary care center. Patients come from all over. It's hard to ask them to come back. However, for those who come, many want to learn more about what is normal after the ICU. We offer them psychiatric and neuropsych referrals. And what they tell us, as we ask them afterwards how the experience was and whether they would recommend coming, is that they have relief, that someone acknowledges their issues. How do we quantify that relief in terms of an outcome? Not certain. At the same time, we're part of a Society of Critical Care Medicine initiative that's looking at maybe ICU patients themselves know how to improve their well-being after the ICU in ways that as physicians we don't. And so they've set up support groups for ICU survivors at 5 sites around the country thus far, and this is growing, and we're one of these sites. Similarly, it's hard to get patients to come, and how to tell whether it's useful, I don't think we know the answer to that yet, but I think it's worth trying. At the same time, we're interested in improving education about ICU outcomes, and so working with a patient survivor who's designed a website, we've designed this After the ICU website. And our goal really is to get patients, families, researchers, and healthcare providers interested in sharing stories and kind of working together online, because it's hard to get people to come in person on sharing their stories and sharing their potential solutions for some of these issues. So here's a screenshot from our website, show you a few more. We asked people to share their stories. We have a couple submissions thus far. We have a glossary, some definitions. And we'll see. I think that we'll see how this website grows. Right now, I think one of the barriers is that people aren't really searching post-intensive care syndrome. People don't define themselves necessarily by having survived the ICU, and perhaps they shouldn't. But as a result, I think that people are sort of slow to find out that some of these experiences that they have are actually the norm. So that's the conclusion of the majority of the content here, and I'd like to go into a couple of review questions. A patient comes to your clinic. She was recently discharged home after an ICU stay where she was intubated due to respiratory failure from COPD. Which psychiatric problems is she most likely to face as a result of post-intensive care syndrome? A, depression, anxiety, post-traumatic stress. B, psychosis, anxiety, post-traumatic stress. C, post-traumatic stress, hallucinations, suicidality. And D, there's no psychiatric problems that have been associated with intensive care unit admission. So the answer here is A. And I'll point you to one citation. A systematic review of 14 studies found the median point prevalence of clinically significant depressive symptoms in ICU survivors to be 28%. A review of the literature for PTSD in ICU survivors that looked at 15 studies found the median point prevalence of clinically significant PTSD symptoms to be 22%, so higher than that brain ICU cohort that I mentioned, where they actually found 7% of people to have PTSD. But from the brain ICU cohort specifically, as I mentioned before, 37% of patients experienced symptoms of depression. And interestingly, their depression largely seemed to be associated with somatic symptoms. Let's do another review question. What's the burden of cognitive dysfunction in post-intensive care syndrome? A, there's no cognitive dysfunction associated with post-intensive care syndrome. B, around a third of patients a year after critical illness might have cognitive scores similar to those with moderate traumatic brain injury. 75% of ICU survivors, or D, 10% of ICU survivors. So the answer here, as we know, is around 1/3 of patients a year after critical illness. And the brain ICU study demonstrated this finding, that 24% of patients had cognitive scores similar to those with mild Alzheimer's, and a third had cognitive scores similar to those with moderate traumatic brain injury a year after critical illness. So that winds up the review questions. And just to return to those take-home messages, in the ICU, physicians, nurses, support staff are all saving lives. But the things we do have long-term consequences, and we don't know how to treat those long-term consequences yet. We do know that practicing good ICU medicine helps with good ICU outcomes. It likely is beneficial to educate patients and families about post-intensive care syndrome. And the burden is on us, really, as we increase the number of ICU survivors to think of creative ways to impact these problems. So I want to end with a couple of references. I'd like to acknowledge from the Brigham my colleagues Jerry Winehouse, Melissa Bowie from psychiatry, Stacy Solomon, who's been very interested and helpful in our efforts from social work. Those who I've learned from at Vanderbilt, particularly Carla Seven, who's created a great ICU survivor clinic there. At UCSD, Robert Owens, who also has his own clinic, has helped me with some research and these slides. The Society of Critical Care Medicine Initiative, and here's my email if you have any questions.